Hello, it's Beth right again, and we are providing, or I am providing you a podcast for Chapter 5 on Unit 2 for your NUR 136 class. And this chapter is about our geriatric patients, our older adults and older. So, just talking about this group, we're talking about that aging. It's a natural process that begins at birth. So as soon as we're born, we start aging. And it begins, related changes begin around 19 to 64 years of age. Isn't that lovely to think about? Older adults are people that are 65 years and older. And polypharmacy is a common issue with this group of patients. Poly meaning many. So you never have, or you hardly ever have, a patient that just takes one medication. They have many medications that they're on. So we have to keep that in mind when we're caring for this age group. You might hear the elderly, this age group called elderly or geriatrics. We use geriatrics a lot. And this is going to be your largest population of clients you take care of when you're in our clinical setting for our nursing clinicals there. And we have, of course, we do hospital clinicals, we do nursing home clinicals, and we also do home visits with our geriatric population in your last semester. So that's always a fun adventure and a very good learning experience for our students. Chronic conditions are definitely a part of that aging, and it can involve anything from the heart to the lungs, cancers, arthritis, diabetes, obesity, depression, substance abuse, decreased sensory perception happens, bone disorders, antibiotic resistant infections, some that's not listed here, stomach issues, liver issues, and renal issues as well. So we see a slew of medical conditions, and many times you'll hear those referred to as comorbidities, meaning additional medical diagnoses that they have. And it's always really important that we look at those medical diagnoses. That can let us know what kind of issues we may have with medications. So pharmacodynamics involves the drug actions on targeted cells and the alterations of cellular reaction and function. And so with older adults, we know that everything starts to reduce, everything pretty much. Maybe a few things not, but for the most part, everything starts slowing down and working. And so one of the things is a reduced number of receptor sites, decreased number of receptors or specific systems in the body slowing down, such as the liver or the heart or the lungs. And so that makes the geriatric patient more prone to adverse reactions when these body systems aren't working or like they should be, or if there's a decrease in the receptor sites or a decrease in the receptors. And Beer's criteria has a list of drugs that have been proven to be harmful or potentially harmful with our geriatric patients, and to use caution for these patients. QSIN, the Quality and Safety Education for Nurses, also provides a list of adverse effects that may occur with specific drugs. Now, your textbook talks about your cardiovascular disease being the number one killer in adults. Talks about hypertension being best controlled with thiazide diuretics, and digoxin is being used with heart disease, and that it shouldn't exceed a certain milligram per day. So we will get specific things directed toward our geriatric population on or for specific medications from time to time. So how do we prevent adverse effects in this population? We know that there are drugs there that produce adverse effects and more prone to do so in older adults. So knowing those drugs. And then strategies to reduce or prevent adverse effects is to assess that patient's medical history. What kind of medical conditions do they have going on? Getting a list of all their medications, and don't forget to ask them about herbal meds or vitamins, supplements, that kind of thing as well, because they too interact with medications. We need to look at their lab results for their renal function, and that's going to be the BUN, the creatinine, and the glomerular filtrate rate. We need to look at their liver function test, and I'll talk a minute about that here just a second. Drug serum levels, where it's applicable, we need to be monitoring those, and also talking to the patient about adherence to the medication plan. Are they taking the medicines that are prescribed? Because we can't assume that. We need to ask the patient, is this the medicines you take, and is this how often you take them? Are there any deviations from what your physician has ordered? And sometimes what you'll hear is say, well, I take that blood pressure medicine when I need it. Or I'll take a half of one when I need it. So a lot of times people are treating themselves out there. And so we need to know that so that we can have the true plan. And you just simply have to say to patients, now, we need to know what you're taking so that we don't give you anything that can harm you or that may interact with your plan, that kind of thing. And if a patient isn't following their plan of care, their medication plan of care as it's prescribed, we need to find out why. We need to find out about the compliance and, ask them, is it because they can't afford it? Is it because of side effects? Is it because they just don't want to? I don't know. So we need to ask them, what the adherence issues might be. We need to provide interventions for any deficiency, of course, and of course educate, teach about the drugs and possible interactions that may occur with drugs, meaning, the drugs that they're on, how would those drugs interact with those other drugs? Are there any drug-food interactions, and are there any drug-herb interactions? So when we think about the pharmacokinetics in the older adult, we got to, again, remember that everything is slowing down and our absorption rate is slowed down. The GI tract decreases in its acidity, its gastric emptying, the blood flow, the surface area, all of that is slowing down. And so that means that things aren't going to be absorbed as they should be. So what's going to happen with our therapeutic level in that instance? It's not going to be where we need it to be. So, there may be a need to increase a dose, maybe. There's decreased circulation, so slower absorption and a decrease in muscle mass as well. With the absorption end of it. So thinking about IM injections there. Distribution, we have a slowed cardiac output with our age, and for the most part an increase in body fat. Now some patients you'll see that not be the case. They actually will have a less body fat, but for the most part folks will have an increase in body fat as they get older. They may have a decreased body mass and body fluids and a decrease in albumin. So again, we got to think about how that affects the distribution. And if you look on in your book on page 77, it talks about, there's some bullet points there, talks about the distribution issues with your elderly patient. But I have seen many times this be an issue with patients. For instance, lipid-soluble medications, anesthetics, okay? So I'm talking about a patient that has gone to surgery, okay, and they're having anesthesia. Anesthesia stays in the system longer because it stores in the fat. So, as so do many drugs and chemicals. And I've seen this be an issue with elderly patients, and they stay sedated longer. So it can be very, very dangerous for patients. We got to monitor them carefully. We got to monitor their respirations and cardiac function, their pulse and blood pressure. We also do a pulse oximeter where we're checking their oxygen level there, and of course checking their level of consciousness. The amount of body fluid decreases in proportion to the total body. So water-soluble drug dosages should be lower than, should be lower with less body fluid for absorption. We may have a low albumin, so, especially with older people who have lost a lot of weight. So if we got a low albumin, those drugs that bind with that protein to get distributed to the receptor sites, we may have an issue there. There may be the free drug floating around and causing more toxicity. So we gotta watch about these things with our elderly population. With metabolism, we have changes with the liver, decrease in size and mass, hepatic circulation decreases, and the metabolic rate decreases. The hepatic enzymes, these are altered ability to remove waste. So we many times have to measure and monitor that those hepatic enzymes. When we talk about metabolism, with all of the things that happen in an older adult, it means that the drug is going to stay in their system longer if they are not metabolizing it. And a lot of times it'll create a longer half-life for the medications. And so that means, it's going to stay in the system, in the body system longer. With this also, the book talks about ethnicity and metabolism, and Caucasians and African Americans are poor metabolizers compared to Asians. Circulating meds, the distribution part for Caucasians and African descent is higher. So we've got to take those kinds of things in consideration. Now, when we talk about liver function test, there's 3 in particular that we really watch with this. One of them is called the alkaline phosphatase, and its initials are ALP. So anything elevated could indicate a liver issue. The second one is ALT, alanine transaminase. ALT is the initials, and that's an enzyme that's found highest in the liver, although it's in other areas of the body. But when these are abnormal, when the results of these tests are abnormal, it means that something's going on with the liver. It's either been injured, or there's some kind of damage or something that's causing those enzymes to be elevated. So that's why we watch those liver function tests. The third one is AST, aspartate aminotransferase, and that again is an enzyme that's found in high amounts of the liver, and it's an indicator of liver issues when those are elevated. And you will typically in the hospital setting, you'll see they'll have a range of what's normal. So anything elevated on these is considered abnormal and a problem with the liver. So we definitely want to watch that. The other things that we look for individuals with a liver problem would be the color of their skin. If they are jaundice, we call that yellowing of the skin and the eyes. So usually that jaundice begins first. We'll see it first in the eyes, and then it moves on to the body. So that many times will let us know there is a some kind of liver impairment going on. Now, excretion, again, we got those age-related changes that happen, so we begin to have a diminished renal function, less nephrons, and our glomerular filtrate rate is less, and our tubular secretions are less. So we got to monitor the renal function. We do that with our BUN, which is your blood urea nitrogen, creatinine, which is these are all serum or blood tests, and then your GFR is a calculation that's done, and that's your glomerular filtrate rate. So any med that has a long half-life may need to be reduced dose because it means it could stay in the body longer and not excreted as quickly as it's supposed to. So we want to again monitor the renal function, and also we monitor how much urine output the patient has. Now we have to talk about medication adherence. I've already mentioned it a little bit, so let's dive into it. The polypharmacy again is risky due to the number of drug-drug interactions that can happen. The more medicines, the more complicated that can be. Also, polypharmacy can be risky because we may have an issue with memory, with remembering. If you have a lot of medicines to take and at different times of the day, it may be difficult for the patient to remember all that. My husband's granny, she would always write down when she took her medicines, what she took, how much she took, and when she took it. And she had notebooks upon notebooks where she kept this information, but it was because she didn't want to overtake something. So that was something that she had a way to control that. Also, things that we've done for clients when we go in for the home visits for clinicals, the students have many times gotten the patient's pill boxes, made them medication charts so that the patient would know what they're taking and when to take it. So you got to think about those age-related changes that occur with patients, like their vision, hearing, their taste, their touch. All of those things start to diminish, and so we have to think about the safety aspect of that and provide teaching and interventions that can help with that. The economic factor is, a definite thing that I've seen many times with elderly patients. They many times are on a fixed income, and so when it comes to buying food versus buying medication, they many times won't buy the medications. They will pay their electric bill or pay their their rent or whatever before they will buy the medicine. So that's many times the case. And again, there are assistance programs out there that can be found for individuals who cannot afford their medication. Starting slow, and with low doses. So again, we got to think about that, and that should be the case with anybody. When patients, many times you're going to get patients who are, and we're going to talk about pain medication, okay, narcotics. Okay, so many times you'll get patients who are like, no, never have taken that, don't want to take it. And we call them narcotic naive, okay? Now, if you get a patient that has not taken narcotics, and you've got narcotics ordered for them, you better start slow and with a low dose, because you'll knock them for a loop. next thing you know, they'll be unconscious and not breathing and that kind of thing. So again, we need to start low. We don't need to give them a whopper dose to knock them out of this world. So sometimes you may see orders that the doctor or healthcare provider will provide you like a range, such as morphine 2 to 4 milligrams for pain. Okay, you want to start with the 2 milligram. And check out the effects. Does it help their pain? But are they able to communicate? Did they lose consciousness? What's their breathing, respirations, and things like that? Because you can really put somebody under there. Okay. Asymptomatic, this is not just with elderly, but many people, they start taking their medicines, they start feeling better, and then they stop taking their medicine because they're feeling better. And that's a dangerous situation, especially when we are dealing with antibiotics, okay, because that can build up a resistance to the antibiotic. So we need to teach patients, not just elderly, but all patients, they need to take the medicine as prescribed and finish the prescription, especially antibiotics. And adverse effects, that also can affect adherence, so we need to teach them about it and communicate to the healthcare provider any kind of problems that the patient brings to our attention so we can get them, on the right medications. I mean, I've heard many patients talk about antihypertensives, about, the side effects that it's causing, and so they stop taking it. Next thing you know, they're coming in with a stroke. I mean, we got to teach, and there's enough medications out there where they can find, be started on a different medication to try to get control of a situation. Okay, just a question here. Economic factors may contribute to non-adherence. And I'm not even going to do the Jeopardy song on this because I know this is true. So again, we can make a difference for patients on this when we know about it. So we got to ask the questions about it. So our nursing process with our geriatric patients, we got to assess the patient's knowledge. What do they know about their medications? Do they know what they're for? Do they know about those adverse effects? Do they know how to take it correctly? What is their medical history? Do they have a history of heart failure, lung problems, liver problems, renal problems, all those things that we mentioned before? What is their current medical status? Are they stable? Are they not stable? I mean, that makes a big difference on many medications that you get. For instance, if you've got an unstable patient, meaning that, their vital signs are not within normal limits, then you're not going to give a newly ordered medication that would affect the blood pressure or the pulse. So current medical status is a big deal, and we got to assess that. And then, are they able to adhere to the medical plan? And if not, then why? The nursing diagnoses, effective therapeutic regimen, risk for fall or injury or risk for injury related to adverse effects, ineffective health maintenance, and readiness for enhanced knowledge. So yes, there's many times when those elderly patients are like, I want to know what to expect here. I want to know what I can do to make this better. Our planning and goals is that the patient will know how to take the medication as prescribed, and that they will report any kind of issues. They will not have any injuries related to the medications or adverse effects, and that they will maintain adherence. And then our interventions are we're going to assess the renal, liver, cardiovascular, changes in body mass, what kind of response the patients are having to the medications, their ability to maintain and adhere to the medical plan. We're going to assess for those adverse effects, and we're going to teach them about all of that. And when we teach, we do verbal teaching, but we also want to give them a handout to take with them as well. And then, of course, evaluation. We want to evaluate what the patient's response is. Did we meet our goal? Did each of the interventions help? Did the patient or the family understand? Is the patient adhering to the plan of care? And also any kind of adverse effects. Okay, that concludes your podcast.